So at the outset, I would like to thank Dr. Jadip Nandi for organizing such a beautiful academic event here at AIMS Raipur. And thanks for inviting me and giving me this opportunity to deliver this lecture or topic. So at present we are running through this IPL season, I think, and we all watch this IPL. So in IPL, when the two team fights, or when the team fight, actually the match starts, so what is the thinking? What all the players think about? Can anyone say why actually they are fighting? Why they are fighting each other? Actually, they have a goal in mind. They want to win the match. This is the only goal for the match is being played. So I think there is one team that is batting side and one is fielding side. But the goal is same for both sides. Both want to win the match. But have you considered those who are batting and those who are bowling? I think both have different strategy. The batting side want to score more and more, and bowling side want to get them out as cheaply as possible. So the batsman or opening batsman who is coming to bat, he has different tasks. Run quickly as much as possible. And the bowler has to bowl as economically as possible. But what will happen? The batsman is doing very good batting, opening is scoring boundary and sixes each and every ball. But all of a sudden what happened? There is one batsman got out. In succession, two batsmen got out. What will happen? The approach, strategy, everything will be changed. The goal has remained same. The batting side want to win the match and score as much as possible. But due to fall of wicket into quick succession, they change their strategy. The third batsman now have to defend his wicket. At the same time, he also need to score the run. And the bowler will again keep the bowling, same Yorker length, good length, or whatever. So do you think only two players are doing this to achieve the goals or playing? The whole team is playing. I think the whole team is playing here. Bowler is bowling, but he has set field accordingly. When he is trying to do a Yorker ball, trying to do a bouncer or full length, good length, he set the field accordingly. So each and every player has playing here to achieve a same goal. Even two sides are playing to achieve the same goal. That is, I want to win the match. So goal is same, but there are so many different aspects are here. So what is goal actually? In a broad way, we can say goal is something which is desired to be achieved in future by individual, a group of persons acting together or alone to achieve something. And here we are talking about goal setting in spinal cord injury rehabilitation. So when Dr. Jaydeep admit a patient in IPD, from OPD, he will advise the patient may be admitted in the IPD for rehabilitation. So you all residents have something in your mind. Why the sir has admitted this patient in IPD? Obviously PMR what we are mean to have this rehabilitation. So we need to set a goal. It's not like that rehabilitation. It's a so umbrella term. We have to become a little bit more specific. That's why I think goal setting is very important. Without goal, you will not get motivation, dedication, where to go, how will you check your progress, whether you are going in the right direction or not. So obviously, it's a devastating blow that results in disturbances to normal sensory, motor or autonomic function. I have taken a quite old definition by Walter and Luker in 1996, the process of enabling and facilitating the restoration of a less able person to regain optimally functioning, that is physically, socially, psychologically, to the level he or she is able to motivated to achieve. The formal process whereby a rehabilitation team together with the patient or their family negotiate and set goals So again here is the team, just like IPL team where we have a team. The center part in this is the patient, the family members, the caregivers, the physiatrist, and the entire team. It's not like that whatever the patient has been desired by the patient is set to be the goal. We have to negotiate with the patient as well as the caregiver or family member scientifically and practically. But the goal once set by the team meeting, that remain to be there for some time. So it consists of 4 elemental or procedural elements: the assessment, evaluation, assignment, and intervention. And for each of the rehabilitation cycle, goals are repeatedly set that determine assignment and appropriate intervention. Like it's not a static, like Amol was saying, static and dynamic. So again, goal is also not a static. It's a dynamic process. Based on your assessment, today you have set a different goal, but after a certain time you feel, no, my patient progress is much more than what we have expected as a team. Then we can go for a higher goal. And again assign different tasks to your entire team. And start with your nursing officers. Like at our AIMS Patna, in our IPD, we have a bedside whiteboard where the goal has been written there from the day of admission. For everyone, goals is written there. For physiotherapist, occupational therapist, prosthetic and orthotist, and nursing officers. Physiatrists are there in everything. And they have to check whether what they have goal as per setting achieved or not. And based on that, we can design our intervention. Why to set goals? Just I said, this is the benefit of setting goal in the management of organization have been investigated extensively. But it has been shown that setting personal goal increases their behavior change, presumably through increasing motivation. That is the desire to act in a particular way. Like many person meet us during company meet, the different goal has been set by their company that you have to achieve this. And for that they came to us, sir, this target has been set by our superiors. So accordingly they are working in that manner. So we also have to set our goals only to be motivated, dedicated, and work in a particular desired path. It's an essential component of structured rehabilitation. So I advocate it strongly that at the time of admission in capital letter you must write the goal for the patient, be it short-term goal, be it long-term goal, but it has need to be written in capital. Like you have to score 20 runs in 3 hours, but it's not like the target is 20 runs. Basically target is 160 runs, but keep the run rate in check. You need to score 20 runs in 2 hours or 1 hour. So we come to provide a structured rehabilitation, and in addition to motivating the team, the patient, the goal setting can coordinate the whole rehabilitation. It has a motivational aspect. It's an essential, important in the assessment of rehabilitation outcome, whether you have won the match or not won the match. Similarly, whether you have achieved your goal or not. So it provides a mean for team member to evaluate the rehabilitation process, to evaluate the planning and the means and methods used. Like Phillips would put it this way: if healthcare processes are to be evaluated, they must be goal oriented, because the appraisal is only concerned with the extent to which goals are attained. Like in many patients, we try to achieve that we will discharge the patient with assisted ambulation. But after a certain time, you realize it is not possible to discharge the patient with assisted ambulation. Okay, let's focus on the bowel and bladder. We can discharge the patient on CIC or independent bowel or regular bowel rather. So your goal has changed here. In the next session, you might admit the same patient with the goal that we can discharge the patient on wheelchair. Again, there are pressure injury, like grade 4 pressure injury, grade 3 pressure injury. You cannot admit a patient for eternity. You have a certain timeline by which you need to achieve this. If you are not achieving this, discharge the patient to a different set goal, and again tell the patient to do follow up. There are criteria like SMART and Rumba. It's relevant, unambiguous about what should be accomplished. Every team member must have a clear-cut view what we are going to achieve in this patient. There is no ambiguity in this, and you must take input from each and every player or each and every member, because very important. If you involve your therapist, involve your nursing officers, in fact involve your family members, patient of spinal cord injury, C6, C5, T4, they are going to lie on the bed for 1 day, 2 days, 1 week, 10 days. It's such a boring thing for a patient lying on the bed for themselves. So to get him motivated and to let him know what we have achieved, because there are certain times very minor changes are happening inside the patient mind, okay, in fact body. In mind so many changes are occurring, but if you let him know these are the things we have achieved, what we have said, then he will also feel motivated. Yes, I am progressing, but the progress is so minute, he is unable to perceive it at present time. So it must be measurable. SMART criteria has so many things they have included recently. Previously, S for specific, M for measurable, A for attainable, R for realistic, T for time based. Now they have added ER. That is, they have made the SMART more smarter by adding ethical and recorded. The key issue which need to be addressed: do the patient and team member always understand the goal planning process? Are the goal always the patient's goal, and or the goal forgotten once the goal planning meeting is over? So regular meeting and over the goal setting, what we have achieved. Again I am trying, a whiteboard is very helpful for us. We included in our IPD in I think 6 months back, before the SCI master class, but it is very helpful. Whenever we are doing round in IPD, the first thing you will notice is by the side of patient bed there is whiteboard, and even if you have forgotten, there is written the goal for this. Then again, you, without reviewing the file, you can ask your PT or OT or your residents why we have not achieved and what you are doing, what you are suggesting, how will it be achieved. It facilitates both the efficiency and the effectiveness of rehabilitation. It needs to be documented, and it will help our journal also, and it will help also us in publication. If we get it archived, if we document in a fashion like achieved, not achieved, ongoing, goal revised and goal abandoned. So we are very honest with ourselves here. We are not like hero, and we are not going to change your life forever. So it's not like that every time the goal is set has to be achieved. India won each and every match in the World Cup. They lose only one. It's quite common. Out of 10 matches, you lost only one. Our players are so wonderful. They did so remarkable thing. But what we remember, the final match against Australia. You could have lost 2 or 3 matches, but why you lost this match? Only against Pakistan you need to win. But after that, how you lose the final match? You are not permitted to lose the final match. But here, actually, we have to admit with gracefulness that goal is not achieved, and it needs to be documented. Then it's ongoing. Goal we revised as per the progress, and sometimes goal abandoned. No, this is totally unrealistic goal our team has set. It's not a team failure. Actually, it is the goal failure. So we will abandon our goal and set a fresh goal. The primary objective goal is obviously preventing secondary complication. Don't let the patient get different complication or in addition to the complication with which he has admitted. Promoting neuro recovery, maximizing function following injury, improve patient ADL, helping a patient accept a new lifestyle. This should be started from day one. Most of the spinal cord injury patients are young patients, 14-year-old, 18-year-old, riding a bike, listening to his music through earbud and everything, and enjoying his life. All of a sudden, his entire life changed. Now he is nowhere going to live that life again in future. So making him accept to this new lifestyle is so difficult. That's why the suicide rate is so high in patients of spinal cord injury. So we need to understand and make the patient understand and accept this is your new lifestyle. Previously you are living a different life, now you are going to live a different life. Life is there, but lifestyle will be different. And to let him integrate into the community. These are our strategies, that is focus on the principle of motor control, activity dependent neuroplasticity. And neuroplasticity is such a mythical thing. We are never able to answer when exactly neuroplasticity appears. It appears within minutes, seconds, hours, years, okay. But actually, as per one of conference I was attending, one of my friends said it appeared within minutes, but I didn't find any reference. The concept, obviously, time is a spine, like in every diseases. But the timing of rehabilitation in patient with acute SCI. Should rehabilitation start early? Everybody say, you start rehabilitation from day one. But what the recommendation said, we suggest rehabilitation be offered to patient with acute SCI when they are medically stable and can tolerate the required rehabilitation intensity. Those strength of recommendation is weak. So when you get a referral to transfer the patient to the PMR IPD by neurosurgery or neurology or medicine, don't rush the patient in a hurry. Talk to your consultant, talk to your head, talk to Dr. Amol, Ronak. Sir, this is the condition of the patient. Should we take the patient? It's not like the other department is setting or saying you can transfer the patient. It's your decision and you have to take that decision, take the call. So see whether patient is medically stable and the planned rehabilitation which you have planning, whether he is able to tolerate it or not. If not, you write in the note sheet that this is the things, that's why we are not transferring the patient at present to the PMR IPD, but we will reconsider our decision in 2 or 3 days or review after 3 days. Don't say yes, don't say no, but say we will review and add to it bedside rehabilitation will be provided in your ward. And you write rehabilitation protocol accordingly, send your therapist. So the burden and responsibility and accountability will still lie with the admitting physician, not with you. Once you transfer to your patient to IPD, which is not medically stable and not going to tolerate the rehabilitation intensity, then you are not going to achieve your goal and the burden will be on you. Again, the key question is adult patient with acute and subacute traumatic SCI. Thus, the time interval between injury and commencing rehabilitation affect the outcome. What is the comparative effectiveness of different rehabilitation strategies, including different intensities and duration of treatment? Are there patient or injury characteristics that impact the efficacy of rehabilitation? What is the cost effectiveness of various rehabilitation strategies? So you see, there are so many questions. Even they are challenging the comparative effectiveness of different rehabilitation strategies, including intensity and duration. So we don't have that much time. The anticipated desired effect of goal setting are improved neurologic outcome, ADL, ambulation, quality of life, reduced rate of mortality, reduced rate of hospitalization, and reduced rate of secondary complication. They have compared between early and late rehabilitation group. They have studied it and they reported that an increased time between injury and rehabilitation is associated with reduced ADL and quality of life. So they are advocating for early rehabilitation, that we all know. When confronted with a life-altering event such as SCI patient, can I have a glass, bottle of water? So we can early rehabilitation would reduce the adverse psychological event occurred due to delayed. And this thing you can get anywhere, okay, like the level of injury based on the NLI, C1, C3, what are the abilities that you can expect? On based on abilities, expected abilities, what are the functional goals you will set? Like here I have chosen this C1 and C3. The functional goals here will be the breathing, communication, daily task and mobility. And what are the equipment you can use here is, these are the equipments. Similarly, each and every level there is certain goal, certain functional goal, certain ability and certain equipment needed. The PowerPoint I have already shared. You can have this. And so, thank you very much. I set my goal to finish in 20 minutes, but 15 seconds I have exceeded. So sorry for that. And thank you all for listening.
Thank you, sir. Thank you, sir, for sharing your valuable ideas and experiences. I would like to invite Dr. Amit Dhumale, sir, Director at Department of Neurorehabilitation, Jupiter Hospital, Pandey, to share his ideas and experiences in early rehabilitation intervention in HDU for brain and spinal cord injury patients.
So before I start the presentation, I just, if sir give me permission just to comment on his presentation. What sir said is so important, because setting goals, and as rehabilitation, our approach is supposed to be interdisciplinary. The approach, which means common functional goals. And I'll tell you, the JCI accreditation for rehabilitation departments in India and all over the world today is asking for forms to prove that your process is interdisciplinary. So we have a form, a case conference form, and we have a multidisciplinary plan of care form written by the PT, OT and speech and signed by the rehab doctor to prove exactly the same thing, sir. So anyway, thank you for enlightening us about that. So I'll get back to our presentation, which is early inter-rehabilitation ICU. So I'm going to try to make this as extempore as possible. Whatever writing you see, just see the headings. Even if you don't read the details, it's okay. We are just going to make it a very practical discussion. So how did this start? Like, before I joined Jupiter Hospital 6 years back. I was working in Qatar Rehabilitation Institute in Qatar. It's a Gulf country. And when I joined over there initially as a specialist, and for 4 years and 2 years I was working there as an associate consultant. I told them that I wanted to work in the neuro department, so in the neuro rehab. So every 3 months they used to rotate us from the TBI unit to the stroke unit to the spine unit, and 3 months in the ICUs. Okay. So I used to feel in the beginning, first month, why have they posted me here? Why are they wasting my time? So I went and spoke to my HOD and said, no, this is a very important part of rehab, and you should go and get certified from the US, which I did, and I'll be showing you the certification from where to do it also. And then slowly I got exposed to that. I understood why rehab is so important, starting right from the ICU. Okay, then I left the job there 6 years back. I joined back in Jupiter Hospital. We made a new department starting from scratch. We planned everything, the place, the rooms, the machines, and everything started. So for the first 3 years, to tell you frank, the first 3 months, I was not having much work. So I used to think, the hospital has invested so much. Is this going to work? Is this going to work? And all the other doctors are busy working. They are having all patients, orthopedic surgeon, general medicine, and I am the only full-time consultant there waiting to get patients. So what I did, I remembered my days, and I decided. I made basically an SOP, and this is the same SOP, and I took that SOP to the critical head, the critical care in charge of Jupiter Hospital, and I just showed him an SOP, and this presentation is just a copy of that. You can convert this presentation into a Word format and make a SOP. I went to the director of the ICU, and I told him that I want to be a part of the ICU. I want to come every day and take rounds over here. He said, why, what will you do? I said, please read this, and tomorrow we will talk again. I went next day and I explained to him like how I can help to make your process more better. Immediately he agreed. He told me we will make a SOP, combined SOP of the rehab department and the ICU department, and we went to the director of the institute, and he gave us the approval immediately, and that's how the process started. Okay. So as you know, there are areas like the ICU and the HDU. So basically ICU, the patient to the nurse ratio is 1:1, and the HDU it can be 1 nurse to 2 or 3 patients also. So we are going to talk about more of neuro. So I was telling you about the course. So this is basically, the concept has now changed from early mobilization to critical care rehab. And there's one Professor Dale, who is a medical director of critical care physical medicine rehabilitation program. So it's already ICUs have started, the rehab part of it has already started coming under the PMR doctors there, and they are working with a team of physiotherapists who are trained to work in the ICUs. Okay, so this particular course is there, it's there once in a year, and if whoever are interested can definitely think of doing this. So there will be physiotherapists and occupational therapists also there, but it's still worth doing it. So this is the one that I attended in 2018. So the target population right now we are talking about the ICUs, because we used to be posted in the neuro ICU basically, because all our cases start from there. So the aim is to collaborate with the critical care team to safely prepare the patient for an active rehab program. The objectives are to improve lung compliance, to optimize the range of motion, strength, to normalize the tone, and to initiate early mobilization as much as possible in a safe way. This is a very important slide applicable to all patients of stroke, traumatic brain injury and spinal cord injury. If you stay in the hospital for too long, the patient who are on ventilator, they can get ICU acquired weakness. It occurs in 26 to 65% of the patient on mechanical ventilation. It is basically, it depends, the risk factors are age, their immobility, long time of sedation, patient has got infection, multi-organ failure, etc. The outcome improved with physical rehabilitation includes increase in the strength and early independent walking. Post hospitalization, we can increase days alive, and the potential benefits are to decrease the delivery and to decrease the duration the person may be on a mechanical ventilator. So this is basically the orientation model which everybody should go through. There are basic steps like basic assessment of the patient, which as medical doctors we already know. Okay, but probably if it's a physiotherapist, I can't send him to the ICU straight. It's an area where you cannot commit mistakes. It's like the aviation field. You can't make a mistake while you're flying from one place to the other. ICU is like that. Somebody's having some lines. You can't go and pull out that line and say, "Oh doctor, sorry, wo line nikal gaya." Patient might die. So it's a very place where the errors have to be minimized and a lot of effort has to be taken towards that. So as doctors we don't need this, but if a physiotherapist in our hospital, they first come for an orientation to us, they are trained under a physiotherapist who is trained to see ICU patients for 1 month, and then only they are allowed to see patients in the ICU on their own. So the basic assessment, we have trained people to review the chart, review the social history, etc. As doctors we can do it. But for physiotherapists, we have told the ICU doctor to make him, they have one paper called the ICU plan of care. Every day they write that paper. All the information which the therapist needs, it's on one paper. So we don't tell them to go and find out also. Just read that one page and they'll come to, now you'll find out what all they're going to see in that one page. So history, chief complaints, the function status prior to the admission, etc. Some important lab investigation, the consciousness level, the cognitive perceptual considerations are very important, because a patient who can obey command is different, who cannot obey command is different. The plan is going to be different. The various areas of we can do a physical examination and others are there. I will not go into the details of this. You all know it. Okay, then understanding clinical parameters, like if the therapist starts doing a session, he has to see the vitals first. He has to note down the vitals. He starts doing the session, and within 3 to 5 minutes he finds that the heart rate is increasing 20%, or the systolic blood pressure changed by 20 millimeters, the systolic is changing. That's a red flag. If you find out what is the baseline saturation, if it's going down below 5% when you start the session, it's again the red flag. Increase in the respiratory rate of more than 30 is again a red flag. This all basic that therapist has to know. So spinal cord injury patients, stroke patients, traumatic brain. Out of this, spinal cord injury patient and traumatic brain injury are post-traumatic. Spinal cord injury might have fallen from somewhere, and the traumatic brain injury might have had a road traffic accident. He may be operated, he may not be operated. He might have had blood loss. He might have had hypovolemic shock. So you have to know what is the hematocrit. Patients, he's there in the hospital. He comes, he gets operated. The HB was 12 and now it is 6.5. You have to know. Okay, that's another red flag. So the ECG, basic assessments of the ECG, we can't expect this from the therapist, but we are supposed to know, to be able to identify cardiac arrhythmias, ventricular dysarrhythmias, heart blocks, atrial fibrillation, etc. If there is anything, even for us, we have to talk to the intensive care unit doctor and then decide the further plan if we have any doubt. So the lines. So the patient in ICUs, your stroke patients, your TBI patients are going to be having so many lines. The therapist has to know, and that is also mentioned in the ICU notes, special lines. So they can just read that and they know what precautions they are supposed to take. So check the lines and tubes, and some lines may be disconnected plied, like basically the EVD drain. You can disconnect it, and the patient, you can make him walk also, bring him back and reconnect it. But they have to know which lines you can do that, which lines you cannot. So the arterial line, direct arterial puncture is used for invasive monitoring. Generally use the radial or the femoral artery. Do not flex the involved limb at the side. Okay, they should be knowing. The CVP measures the blood pressure in the large veins of the body. Normally it is 0.8. Usually there is no restriction to early mobilization in this. The patient with the IABP supposed to be an unstable patient. So ideally there will be no reference for physiotherapy for this patient. Similar for this line also, the patient is unstable. Only thing what you can do is splinting and therapeutic positioning. That's all. So like I was telling you, you talked about neuro cases, traumatic brain injury. Okay, most common diagnosis traumatic brain injury. Your patient may have normal pressure hydrocephalus, or he may be having high pressure hydrocephalus. So how do you treat that? You have to identify, treat that. The surgeon might have done the decompressive craniectomy also, or some patients are on basically might have done a lumbar puncture, or some patients are there on the EVD drain. Because that's what they do at that phase. If it remains persistent, they might do a shunt procedure. Okay. So basically, these are some of the things. This EVD can be disconnected, and the patient can be mobilized and can be brought back. The assigned nurse must clamp the EVD prior to mobilization, and generally you don't clamp it for more than 30 minutes. Okay, so the head end of the bed is usually kept at the level. So the tragus is actually aligned to the level of the EVD ring. So these are some things which you need to know because of the pressure. And this is what I was telling you, the VP shunt. If that's the final, like you have done the EVD, not solving the purpose, you might wait, but later on you might go for a permanent solution to the hydrocephalus. This is a ventricular peritoneal shunt. Okay. So again, when the patient is usually having hydrocephalus, we avoid activities that increase the intracranial pressure. These are all the activities that you are supposed to avoid. And this is very important for traumatic brain injury patient, but also for stroke patient who have had a massive hypertensive bleed, and they also have basically hydrocephalus. Even for them, the same thing applies. So many patients, they might have kidney injury also, like acute kidney injury following road traffic accident. Multi-organ failure is very, very common. Patient may be on plasmapheresis or hemodialysis. If the patient is there, usually in bed mobilization after 6 hours, out of bed mobilization after 12 hours. If a patient has got hemodialysis, usually after that he is very, very weak. We don't do the session after that for 12 hours at least. That's what usually the hospital follows. Now medication. So don't go into the details of this. This is going into a big detail, but I'll just tell you. If you have this patient, stroke, traumatic brain injury, spinal cord injury, what are the important medication that they may be on? One, the patient may be having hypertensive bleed. So he's got high blood pressure. So he might be on antihypertensive. What are the two major categories of antihypertensive? One, they might be vasodilators like sodium nitroprusside, or it might be nitroglycerin, or it might be hydrazine. Okay, they can be on that. If the second category of antihypertensive is the adrenergic inhibitors, which are basically labetalol. That's one of the. He may be on that medication also. Then that is about if the BP is high and you are trying to bring him down. So that's a red flag. You can't go and start doing resisted exercises for this patient. Then the patient after accident, he may be in shock. Patient may be in shock. So what do you give to the patients in shock? We give vasopressors. Second very important like epinephrine, norepinephrine. These are also patients who BP is low and we are trying to get them up. Basically unstable patient, and ideally except for splinting and positioning and breathing exercise, nothing more is supposed to be done. Finally, third class of medications, inotropic drugs. Why do they give this? To increase the myocardial contractibility, and the drugs are what? Digoxin, dopamine. This is what we need to give to the patient. Again, you have to take care because the patient may not be completely stable. So these are basically the red flags, and the rest of the details, if whoever is interested can go ahead and read. This is the same thing they're talking about thrombolysis. So if a patient has undergone thrombolysis, wait 20. If he is fitting the criteria, he comes in the golden period, undergoes thrombolysis, wait for 24 hours post thrombolysis to initiate early thrombolysis. To initiate the early mobilization. So DVT and pulmonary embolism are very common complications. So active therapy can be resumed after 24 hours following anticoagulation. The ideal INR therapeutic range should be 2 to 3. Okay, so the pulmonary embolism, if it happens, it's a medical emergency. Hold all rehab intervention. Patient may need to be placed with a IVC filter. The patient will be on bed rest for 6 hours following the procedure, and the rehab therapy may resume once cleared by the medical consultant. So some safety protocols. So when therapist goes, are they supposed to also, if they have a referral, they are in the ICU, they are supposed to do the safety screening before they start seeing the patient. What is the safety screening? We call it the MOVE protocol. M is the myocardial stability. There should be no evidence of myocardial ischemia in the last 24 hours. The oxygenation, the FiO2 should be less than 0.6. This is if the patient is on the ventilator. You will see it in the control panel. And the positive end expiratory pressure should be less than 10. Then you can do some exercises. If it's more than that, usually we don't do any in-bed exercise also for these patients. Then vasopressors, there should be no need of vasopressors or antihypertensive or ionotropic drugs within the last few hours. That means that the person was not stable. We have to give time for the patient to stabilize. And also they have to check whether the patient is engaging to verbal response. So this is one rehab protocol, what they say. This was actually in 1990. It's a very old protocol and a lot of changes have come. We'll be also seeing that. This old protocol basically is simple from level 0, 1, 2, 3, 4. First one is passive limb, range of motion and chest PT. Then level 2 is active assisted. Then sitting support with that for 20 minutes. Then the next one is that you try to sit without the supports of the hand, etc. And then you transfer to the wheelchair, and finally the patient walks. So depends upon condition to condition, because spinal cord injury can be complete or incomplete. Traumatic brain injury might be mild or it may be severe. So the patient is going to be very, very different. So this is the thing. Now everybody said there is something which is very wrong with this. If the patient is understanding, this is fine. If the patient is got traumatic brain injury and he is not able to follow simple command, he is in a minimally conscious state or he is in delirium, then what are you going to do? This doesn't work. So somebody came out in say around in between 1995 around 2000 they came up with this they started applying this RAS code, the Richmond agitation and sedation scale, which is from +4 to -5. They have made various categories of wakefulness, and then they have also told you if it's -4 and -5 it's passive range of motion, if it's -3 and -2, and if it's -1, 0 or +1, then what all can you do? So good, something went in the positive direction, but it was not really that good. Then in the year around 2000, a very, very interesting study came, and it has revolutionized the ICU of the ICU rehab of neuro patients, which is this. So this was in basically a study from Belgium. This combined both of them. You know that level I told you, level 0, 1, 2, 3, 4, it was combined with the RAS score and the Glasgow Coma scale, and you can see how beautifully they have explained. If it's level 0 or 1, if the RAS score is -5 to -2, if the Glasgow Coma scale is less than 8, so you move from this passive and you go to active assisted and you go to active. But that is not it. They have also told you when you can passively transfer the patient to the chair and when you can actively transfer the patient to the chair. They have also told when you can start the in-bed cycle ergometry very, very, very early. They have talked about verticalization, which is the tilt table or the combilizer. I am going to show you that in the coming slide. Also talk about standing and talk about active exercises when it can be done. So I think we are also using this, and it's a very good study to actually scientifically treat the patient in the ICU. So various rehab interventions are there. I will not go into the details of this. Like I told you, most of the patient we can start at least on the pulmonary rehab part. And the various rehab interventions which people do in all neuro cases, all you know about, but it depends from patient to patient. Now that's where the rehab doctor input comes, to make a plan for the physiotherapy or to make a plan with the physiotherapy. I am ready for that also, but we have to be a part of that process. Okay. Then I will talk about some of the machines which we use in the ICU. So this machine known as a SARA combilizer, it has got two modes. That got the tilt table mode and the sitting mode. The tilt table mode is used to treat the orthostatic hypotension, and the sitting mode is used to transfer the patient to the wheelchair as soon as possible. The SARA Plus is a mechanized device which helps the patient to sit to stand. Maybe he can't use the walker, but he's still active. So he can use something like this, but you can use this only when you have treated the orthostatic hypotension. You don't want him to stand and get a drop in BP and get chakkar and fall. So you do the SARA combilizer, and then you might come to the SARA Plus before going to the walker. This is the SARA study. It's another device. If the patient cannot use the SARA Plus, which we saw before, he can use this device. It's a most supported device, and it can help in half sit to stand, etc. Also, you can hit the overhead ceiling rail system which are there. We don't have it in the ICU, but we have it in our department, connecting it from, because we have a dedicated exclusive rehab ward. Connecting the ward and the training area, which is just next to each other, we have an overhead rail system from each room to each bed, which can take the patient out. So as how paralyzed the patient is, he can be taken out with one person in 5 minutes and be brought back in 5 minutes. And this is the Motomed letter, which is the in-bed cycle, can be used in the ward also, HD also, and in the ICU also. So like I said, my strategy was, when I came to a corporate hospital in Mumbai, I did not wait for patient to come to me. I want to apply rehabilitation into the complete spectrum of care, right from the ICU, because why it's so important to go to the ICU? Helpful for the patient, yes, but I get entry into the ICU. I can select the patient. This is patient fitting into the inpatient rehab category. Take him to my inpatient ward. Don't take him to the general ward. He's fitting into an inpatient category. I arrange for my source of patients. You understand what I'm saying? So it's very important from that point of view also. And then the patient comes to inpatient, then he gets discharged, then we have an outpatient program, and now we have also through Jupiter Home Care started home care rehab also. So I have just 3 months back we have completed the complete spectrum by completing the home care rehab also. So once a patient is discharged, and those who cannot come home, our therapists from our hospitals in non-working hours go and do their therapy, and that helps us, because it helps the therapist to stay with us. In the private, the attrition rate is very high. People come and go. But since we have started this program, not one therapist has left and gone. Touch wood. I hope when I go back, nobody resigns. So coming to traumatic brain injury, I told you what are the cause of concerns. Is basically hydrocephalus. Understand that, what machines you can use, and the previous what we have read should help you in taking a decision. Patient may have a craniotomy or a decompressive craniectomy, and we need to know that. So the early mobilization, if he is minimally conscious, is also by using what we discussed. We can use that to actually early mobilize the patient. Now, traumatic brain injury may be mild or severe. Now, if you take one of the type of injury, like one mechanism of injury, like diffuse axonal injury, it's like a turning motion. And grade 1, 2 and 3, as you go deeper, the grade goes on increasing. So the patient, in one case he might be completely fine, but in one case he is not responding at all, minimally conscious state. So if you look to the right, if he is a very severely affected patient, only coma stimulation program and condylizer can be done. But if it's an active patient, if it's a mild or moderate traumatic brain, you can even start with the in-bed upper and lower limbs cycling, the SARA study and the SARA Plus. Okay, coma stimulation program, if I talk, there's another full lecture on that. Coma stimulation programming, if the patient is in coma, you have to have a scale, like we are using the Rappaport's coma, near coma scale to objectify the level of coma the patient is. And then we do multisensory stimulation program, and every week we keep on doing the Rappaport coma, near coma scale to see the improvement in the coma. It's very sensitive. You should try this for all your minimally conscious patients. And so this is about traumatic brain injury. In spinal cord injury, he has had an accident. He doesn't have any brain problem. He's obeying all commands, all fine. So also if we follow the normal 0, 1, 2, it's fine. But it could be complete spinal cord injury, it could be incomplete spinal cord from ASIS, A to C, it could be anything. So the patient might have had a surgery with multiple fractures. You have to see that does he have any other fractures, so you know the weight bearing status. Has the ortho operated on him? If only spine is operated, is the fixation good? Has he been told to wear some brace? What is the weight bearing status? I can't take all decisions on my own. I have to talk to the spine surgeon about this, and we take a decision together because he has operated the patient. Okay, like you drive a car, like you can't drive unless you look behind in the mirror, right? So we have to know what is happening, and then with the orthopedic surgeon, spine surgeon, we have to take decisions. This builds relationships. This is what I do with all the people. They should trust you, and then that's when they start referring you, and they will not refer any other physiotherapist. Okay, because you're telling them what's the difference between them and you. Then again, if it's a complete spinal cord injury, just operated, we have to wait for the hemodynamic stability, and we can use the combilizer. Combilizer tilt mode and the sitting mode can be started. Obviously, we are taking the spine surgery into consideration. And if it's an incomplete spinal cord injury like C or D, then we can go for Motomed, SARA Plus, SARA study, etc., etc. For the other patients who are more severe, we wait for them to be stabilized, we start the combilizer tilt mode in the ICU itself, condition them and take them directly to our dedicated neuro rehab ward, and we start an inpatient neuro rehab program for them. Earlier, we have taken them earlier, we'll be able to take the patient on the body weight supported lower limb robotic gait training. So if I don't start this over there, I'm going to wait for another week till the patient actually, I can 1 or 2 weeks, I might take him on the combilizer, because to take him on the body weight support system, because that's the patient is going to be suddenly vertical in that. Have you treated the orthostatic hypotension? This is a very, very big question. Okay, so no need to read these things. It is a future directions, etc. So I would just like to request if Dr. Nandi, I don't know, maybe he's busy somewhere. Sir is here. So actually, I was wanted to know your feedback also. What you feel that maybe you can even just take this presentation and make it into a word form, and it can be like you can talk to the ICU director. He must be a friend of yours also, sir. And we can definitely start thinking about this thing, because it will increase our visual presence in the hospital, and it is really going to make a difference. And they, being medical doctors like us, they will understand, and that's what is my experience. When I showed him the paper, next day immediately he told me, make an SOP, we'll make a combined SOP between rehab and ICU, and we'll do this. So anyway, I thank you all for a patient hearing. Thank you.
Thank you, sir. I would call upon Dr. Anirudh Chirania, sir, COO of Apopos Rehabilitation Hospital, Hyderabad. Sir will be talking about tracheostomy care and management of its complication.
And management of complications, but then I realized that management of complications has become a big thing. So I changed it to tracheostomy care and the weaning protocol from tracheostomy. A tube which is put inside an opening in the trachea, which is known as tracheostomy. So we can see that what is the position of the tracheostomy tube. Generally it is put below the vocal cords and below the cricoid cartilage. So what are the indications of tracheostomy? So tracheostomy is done when a large object is blocking the airway, when the patient has a respiratory failure or arrest and is put on a ventilator for a prolonged period. The patient who has severe neck or mouth injuries that can interfere with his breathing orally, blocked or swollen airways in the case of poisoning, mostly burn injuries, cancer of the throat or the neck, the weakness of the bulbar muscles, post-laryngectomy patients, and patients who require long-term oxygen therapy by a mechanical ventilator. So what will be the advantages of a tracheostomy tube? So I think most of you must have seen endotracheal tube. Now the role of tracheostomy tube and endotracheal tube is the same, but because the endotracheal tube is a longer tube, it goes inside the trachea through our mouth. There are certain limitations with it. So pulmonary toileting is possible with both the endotracheal tube and the tracheostomy tube, but oral hygiene is better with the tracheostomy tube. As the length of the tracheostomy tube is less, the dead space is reduced, so the airway resistance is reduced, and it is possible for us to wean the patient of the ventilator. Then with a tracheostomy tube, when the patient is good enough, we can use the speaking valve and the patient can speak. Swallow and speech therapy can be done better with a tracheostomy tube, and there are patients who have been on tracheostomy tube for a prolonged period, but still they are able to swallow. Tracheostomy tube reduces the chances of sedation, and as I said, that because the work of breathing is reduced with the tracheostomy tube, the need of mechanical ventilator is less. So tracheostomy tube is generally done in either the ICUs as an emergency procedure or in the OTs as a surgical procedure. These are the instruments used for doing the tracheostomy. Now there are different types of tracheostomy tubes. There are cuffed and uncuffed tracheostomy tubes. These are the types of tubes based on the material to which they are made. We generally use the PVC tube, or generally know the Portex tube. Metallic tube is not used nowadays. Silicone is better, but silicone tube always has a chance of kinking. This is a type of tubes based on the structure and how they can be used. So as you see that Cuffed and uncuffed tubes are there. Fenestrated tubes are there, which have certain advantages and disadvantages. There are single cannula tubes and double cannula tubes. So they have their own benefits and disadvantages. We generally use the double cannula tube because it's easier to clean the tube so that the chances of tracheostomy blockage is less with them. So these are the different types of tracheostomy tubes. We can see. I will read them out. Okay. So this is a typical tracheostomy tube. This is the cuff tube, and we'll go with this one. Okay. We'll go with this one. This is a typical tracheostomy tube with fenestration. This is the outer cannula. This is the inner cannula. This is the cuff which has to be inflated to keep the tracheostomy tube in position. And this is the cuff, and this is the balloon through which the cuff is inflated. So when we speak about tracheostomy tube care, there are certain things that needs to be done. One is regular suctioning of the cannula or the tracheostomy tube. Second is regular dressing of the tracheostomy tube. So there are two types of suctioning, open and closed suctioning. Closed suctioning is done in patients who are on a ventilator or a BiPAP machine, and it is done when we don't want to reduce the peak. In our ward, we generally just follow the open suctioning because we don't get patients who are on a ventilator or a continuous BiPAP. So these are the tools which are used for suctioning of a tracheostomy tube, and this is the procedure for open suctioning. The most important thing is taking care of the thing that we follow a sterile procedure. So hand rub is most important. Second thing is the suction should not be active when the suction catheter is going inside. We should always suction when the suction catheter is coming in outside, and it should be done in a circular manner. No suction should be not done for more than 15 seconds at a time, because sometimes people might have severe bronchospasm because of this. So all these things you can just see. Ideally, a single person can do the suctioning of a patient, and suctioning is done once in every shift. Ideally, it should be done once in every shift, and if required, if the secretions are more, we might have to do it more often. Then comes the inner cannula cleaning. As I said, that we generally use the tracheostomy tube which has an inner cannula. So it is done very frequently. Again, as I said, that once in every shift, and the patients have to be monitored. If the secretions are thick, we might to do it more often. Again, as I said, the most important part is making sure that we follow a sterile procedure. So the two things that we use for cleaning the inner cannula is hydrogen peroxide solution to remove the crust over the inner cannula, and making sure that it is put in a proper position after it has been cleaned. This is the. Now comes the dressing. So whenever we use the tracheostomy tube, we generally use something called a thermovent, which is a heat and moisture exchanger. So thermovent is always used to keep the secretions moist, to make the secretions thin. And generally what we do is we put the patients who are having thick secretions on nebulization with warm normal saline. And most of the patients receive a nebulization with warm normal saline around 3 to 4 times a day. That will liquefy the secretions, so that will reduce the chances of inner cannula getting blocked and lung quality will be good. Second, after each and every nebulization, the patient is tilted, the handstand is turned down, and patients are rotated, turned left and right lateral position, so that the lower part of the lungs can be cleaned properly. So again, these are the standard things, nothing much. Dressing is done just with a 0 point with a normal saline. We don't use any kind of separate cream or solution. These are the different steps that we follow for dressing the stomach. Now the most important part is the pressure of the cuff. The pressure cuff can be high pressure or low pressure cuff. We generally use the low pressure cuff because too much pressure inside the cuff can lead to necrosis of the mucous membranes. So we make sure we use a cuff manometer, and generally the pressure is not increased beyond 30 centimeter of water. So these are the things that are generally used. This is the respiratory cuff manometer I was talking about. This is the thermovent, which is basically a heat and moisture exchanger, and these things will be used when I speak further about the decannulation process. Now this is a very important cleaning protocol. We generally tend to overlook it, but around 3.5 years back we were getting a lot of patients who were having infections, and we were regularly getting calls from the microbiology department saying that our infections rate has increased. So what we did is we changed the whole cleaning protocol of the patients, starting from the floor to the beds and all the equipments. So these are the specific equipments which are generally used for cleaning the patient's floor, beds of the patients, and the other equipments. We use a multi-enzyme cleaner to clean the suction jar as well as the oxygen flow meter, and we saw a significant reduction in the rate of infection after we started this protocol. Second thing is, we all speak about hand hygiene, but it is not usually monitored. So what we started doing is we changed our hand sanitizer. Instead of just alcohol-based hand sanitizer, we started using a alcohol-based hand disinfectant which had 70% isopropyl alcohol, 0.5% chlorhexidine and glycerin. So that also reduced the rate of our infections. Now these are the early complications of tracheostomy. As the tracheostomy is not done in our ward, it can be seen generally in the ICU, and the people up there are good enough to take care of these things. Second thing is later complications of ICU tracheostomy. The most important complications that we see are formation of a granulation tissue. Second is tooth secretions which can block a tracheostomy tube, and sometimes patients might have a lot of irritant cough, so which might not get relieved with anything. So the only solution that we find is using a lignocaine spray that significantly reduces the irritant cough that this patient has. These are the long-term complications. In the last 8 years, I have seen just 2 patients who had a granulation tissue that had to be managed by a surgery, and there was 1 patient who had a tracheomalacia. So, and post decannulation, what we generally see is that most of the stoma close automatically within a week's time, but some patients who are on a tracheostomy tube for more than around 4 months, there might be epithelialization of the tract, and in those patients we might have to go for a surgery to close the stoma completely. Now decannulation criteria, I think this is the most important part for which the patients are referred to us. So a patient is fit for decannulation when the patient is conscious, alert, obeying commands. There is no need of a ventilator. There are less secretions. Generally we say not more than 2 suctions in any shift, that is not more than around 6 suctions in 24 hours. The patient should be able to obey commands. Generally we see that most of our patients we are able to decannulate, have a good swallow, and we are able to take orally. There are just 2 or 3 patients we have seen who were decannulated but still they were not able to swallow. So these are the this is the most important pathways that we follow. So what we do is, first of all, the patient who is on a tracheostomy, we initiate the swallow therapy as soon as the patient comes to the ward. Once his swallow is good and we are sure that there is no aspiration, the cough is deflated. If the patient tolerates the cough deflation and he doesn't cough, that means there is no aspiration of oral secretion that might have been collected over the cough. But if a patient who is on a tracheostomy tube and the cough is deflated, if he starts coughing severely on deflation of the cough, that means the secretion he was having aspiration of the oral secretions which were getting collected over the cough, and as soon as we deflate the cough, those secretions were going inside the lungs. That's why they cough a lot. So we wait for some time, or we can go for an FLP scopy where the ENT consultant will tell us whether there is pooling of secretions or any other problem. So generally, if this is the issue, we continue with the swallow therapy. We wait for around a week time and again do the FLP scopy after a week. So our initial goal is that the patient should be able to tolerate cuff deflation for around 24 hours, and during the cuff deflation he should also be able to take orally. Second thing is, once the patient is able to tolerate the cuff deflation for 22 hours, respiratory therapy goes with the glove finger occlusion, where the thermovent is removed and the opening of the tracheostomy is closed with the finger. If the patient tolerates for that for this finger occlusion 3 to 4 times a day for around 1 minute, it means that he is good for going on a speaking valve. Now, speaking valve is something where the patient is able to inspire. It's a one-way speaking valve. The patient is able to inspire the air through the tracheostomy, and while exhaling, the valve closes, so the patient will exhale through the normal airway and he will be able to speak. So, but if we see that if the patient is not tolerating a one-way speaking valve or he coughs a lot, then the best thing would be to downsize the tube, because sometimes if the tube is large enough and when we deflate the cuff, the pathway might not be enough for the patient to take adequate amount of air. So downsizing the tube generally helps a lot, and we have seen that patients who are on a larger tube, when the tube is downsized, they start tolerating the one-way speaking valve better. Now the last thing is, once the patient is able to tolerate the speaking valve for about 24 hours, we start putting a decannulation cap. The difference between the speaking valve and the decannulation cap is, speaking valve is a one-way pathway, so the patient can inspire through the speaking valve. But when we put a decannulation cap, the tracheostomy tube is completely occluded. So all the air comes and goes out through the natural airways. The only thing is, whenever we put a speaking valve, we should always remember, we should never forget to deflate the cuff, because that will lead to complete obstruction of the airway and he won't be able to exhale. Similarly, the thing is with decannulation cap. Once the patient is able to tolerate decannulation cap for around 4 hours, that means his airway is good enough, his breathing capacity is good, and we decannulate the patient. So this is the general policy that we follow. You can all have a look when you see this presentation. So this is the number of patients that we have admitted in the last 3 months. These are the number of admissions every month. And what we have seen that is fortunately we didn't have a need for decannulation or detracheostomy of any patients to be decannulated. The average duration of decannulation of a patient who comes to our facility is around 27 days.
Thank you, sir. And now it's our last lecture for the day by Madhusree Sengupta ma'am, consultant and head at the Narayana R.N. Tagore Hospital, Kolkata. Ma'am is going to present on neurogenic bladder rehabilitation and role of UDS.
A very good evening to all. So coming to AIIMS Raipur is homecoming for me, coming back to my roots. So after all these important, slightly superior topics, I will bring all the PGs back home to deal with the bladder. Okay. So this is something very basic. Many of the slides in this presentation are from my PG days, and I've put them in a point-wise way. The reason I'll tell you, I'm a very last-minute person. So before the exams, I used to depend a lot on the PPTs. So I hope that helps you. Even if I don't go through all the slides, for a quick 10 minutes recapitulation, maybe this will help you. So I'll keep it simple and basic and rooted. Okay, so though we say it's a neurogenic bladder, actually you're not dealing with the bladder. It includes the whole bladder, the urethral sphincters, pelvic floor dysfunction, caused by a variety of congenital or acquired pathology of the central or the peripheral nervous system. So the nomenclature has changed now. It is called the neurogenic lower urinary tract dysfunction. So these are the different causes. I will not go into details. Okay, So a quick recapitulation of the neuroanatomy. See, there is a sympathetic neuron and there are parasympathetic fibers. So the sympathetic fibers, they come from T10 to L2. And what will they do? They will come via the hypogastric nerve, and they will, on stimulation, they will cause the contraction of the sphincters and relaxation of the bladder. So there are the B3 fibers in the bladder, and there will be the alpha adrenergic fibers in the urethra, internal urethral sphincter. Coming to the parasympathetic fibers, they will come via S2, S3, S4. Now they will have two routes. One is they will come through the pelvic nerve, and they will come through the pudendal nerve. The pelvic nerve, when they come to the pelvic nerve, they will do the opposite work of the sympathetic. So they will cause the relaxation of the sphincters, and they will cause the constriction of the detrusor muscles. And the one that comes through the pudendal nerve, the fibers, they will affect the external urinary sphincter. This is the basic idea. So all our pharmacology, all our management is a mix of these ideas. For every team there has to be a team leader. The team leader here is the Pontine Micturition Center. So the Pons will decide that yes, this is the voluntary micturition center, now it's time for you to urinate. But leaders will often have leaders above. Okay, so who are the leaders above? There's the cerebellum, there's the basal ganglia, there's the cerebral cortex. So they keep the leader in check. They have an inhibitory effect on the Pons. So they will tell the Pons be in control, and when you are going for a voluntary micturition, the Pontine Micturition Center will give the stimulus. There's the spinal reflex, and then the gradual, step-by-step sequential micturition happens. So if there is an upper motor neuron lesion, the leader of the leader is damaged. Okay, so there is nobody to control the leader. As a result, what happens? There is urge incontinence, and there is incontinence and frequency and everything else. Okay, so when you get time, put in some time to go through this neuroanatomy, because if this is clear to you, as I said, a lot of the management is very clear to you. Now, how will you evaluate a neurogenic bladder? One is, of course, the complete history, which is both urological, neurological. You ask for the symptoms and the signs. So what exactly are you having? Hesitancy, frequency, retention, leak, medication. Is the patient on indwelling catheter, on CIC? Because remember, only neurogenic bladder is not the point. Usually a neurogenic bladder will have effects on the sexual life, will have effects on the bowel activity of the person. So it's a kind of round, complete rehabilitation that you have to do. Look for the reflexes, perineal, pelvic, rectal examination, patient's cognitive ability, mobility, sitting balance, hand function. Keep a voiding diary, what we call as the bladder diary. Now, it might not be possible for you to do a urodynamic study for every patient, but a good bladder diary goes a long way in maintaining or helping you to decide the pharmacological management of the patient. So approximately 2 to 3 days of bladder diary should be enough. Go for a baseline urine analysis and renal function laboratory. Why? Because again, when you're planning for UDS itself might cause UTI. So it's very important for you to rule out UTI before you do UDS. And the initial imaging of the upper urinary tract, you can go for a USG. Check for the PVR, which could be again through the USG as well as bedside clinical. And finally, you can go for the urodynamics. What about the cystoscopy? Now, cystoscopy is something I didn't have much idea about. This is Prashant sir here? These are all Prashant sir's residents who had taught me cystoscopy in CMC Vellore. So, it's very useful. You can do it for when patient has hematuria, recurrent symptomatic UTI, recurrent asymptomatic bacteriuria, or if there's a long-term indwelling catheter, which is about 4 to 6 weeks. Again, if you know the skill of cystoscopy, you have something very important in your hand, intravesical therapy. Now coming to urodynamic study. The urodynamic study itself is a very huge thing. I will not go into the detail. As a PG, you don't need to know everything of everything, but you should know the basic of most things. Okay? Go through this article which the reference have given. It's a very nice article which will give you step-by-step idea about the urodynamics. So download it and go through it. What are the indications? Like I said, in a government setup with so many patients, you cannot do UDS for every patient. So maintain a bladder diary. You do a pharmacological management, behavioral management, everything that you have to do based on bladder diary. Suppose even then you see that you're not getting a good continent bladder, your management is suboptimal, then UDS is where you have to go. And these are the basic recommended indications: recurrent UTI, urinary incontinence, frequency, large PVRs, where there is deterioration of upper urinary tract. You have to monitor voiding pressure. Then you want to know the effect of your management, pharmacotherapy, and sometimes silent dysreflection. They during voiding is present or not, that also you can decide. Now, how many of you all have done UDS? Do we have a UDS here in Instruct?
Yes.
Okay. So when you select what kind of test you have to do for urodynamic study, you will see there are lots of options coming up. You might have a uroflowmetry, a CMG, a pressure flow. So this is again something special with the physiatrists. We usually go for the entire urodynamic study. We go for the cystometrography, we go for the electromyography, and we go for the uroflowmetry. Unlike most urologists who only do the uroflowmetry. Okay? So if you know UD as well and you are ready to bear that time, this is something nobody else is doing. So you have a lot of reference that way, whichever sector you are in. So how to prepare for UDS? Again, first patient should not have any UTI. If the patient has UTI, give antibiotic, let the UTI be cured, wait for the second sample, and then you go for UDS. Rectum should be empty, whichever method you go for. Patient is asked to void before the study to estimate the residual urine, and before CMG, bladder should be emptied completely. How you can introduce a catheter and do it? And recording of the BP. Very important because there might be autonomic dysreflexia during UDS as well. Okay. One question is often asked to me that do you have to do coverage of antibiotics? Better to do. There are multiple consensus, but most common consensus is a 3-day antibiotic will suffice. So these are the different urodynamic parameters that we go for: the filling rate, the first sensation, the first desire to void, the strong desire to void, the maximum cystometric capacity, what is the bladder compliance. Compliance is the difference of the volume divided by the difference of the pressure. The detrusor leak point pressure, at which point is the urine moving from the bladder into the urethra. Maximum detrusor pressure at end of filling. And while voiding cystometry, you see the peak flow, you see the opening detrusor pressure, you see the maximum detrusor pressure during voiding. What is the volume voided? After that, again you introduce a catheter to see whether there is any residual urine, and if so, then what is the residual volume of urine. Okay. Now, this is what a basic UDS graph looks like. Now, many centers you might have a UDS technician. There's a specialized post for it. Even if there are UDS technicians and everything is recorded online or recorded in the graph, sit through the entire UDS session as a resident or even as a consultant. You know, a lot of events which might not be recorded on the graph, but by patients, maybe verbal response or something that you have noticed, you will be able to get a much clearer picture. Your bladder management will be much correct. So sit through it. So this is what a basic graph looks like. You have the EMG, the detrusor pressure of the abdomen, the pressure of the detrusor, abdomen, and you will get in the flowmetry a bell-shaped curve of how the urine is being voided. Again, when the urine is being voided, you check at that point what was the P-depth, what is the P-abdominal pressure. Okay, all this helps you in pharmacological management. So this is just, I've given you a list of what are the normal parameters for a quick reference. I will not go through all of them. What is bladder compliance? So basically, when you give a report of urodynamic study, you always have to first you say the patient name, age, etc. What is the clinical condition? Whether the person was in indwelling catheter or CIC, what was the method? Then you say what did you observe in the filling phase, what did you observe in the voiding phase. Write down your observations. What is the highest maximum P that you observe? What are the, like I said, small events, like the patient complained of pain. The pain might have come before the contraction, you know. So these things you record, and then you give a proper urodynamic study report based on the different phases. You don't really have to categorize a bladder all the time, because in practical scenario, most of the time you might get a mixed pattern. You will not get a perfect pattern, okay? But if you know all the phases where things are going on, again that will help you with the management. Now when you classify the neurogenic bladder, it can be done anatomically, functionally, or with urodynamics. Now anatomically, again, So it's supraspinal, suprasacral, infrasacral, whether it's caudal equina or peripheral autonomic. And functionally, whether it's reflex, uninhibited, autonomous, motor paralytic, sensory, and the urodynamics based. Now, again, you will never ever get a clear-cut bladder. This is perfect, okay? Usually what you get is a mixed pattern, which is a combination of all these ideas. But again, these few next 4-5 slides are from my PG days, which I had made because it helped me remember and conceptualize. So it might be of some use to you. So, for example, a suprapantine supraspinal lesion. Okay, what am I expecting in the urodynamic? There will be detrusor hyperreflection. There may not be detrusor sphincter dyssynergia. Okay, that is an uninhibited bladder. So patient will come with frequency, urgency, urge incontinence. These are the situations where you might find these. Coming to suprasacral spinal cord lesion. So again here, DSD is the rule. You will get a reflex or automatic bladder. So the bladder tone will be increased, the residual volume will be small. Again, patient comes with urgency, frequency, urge incontinence. So in the UDS, you might find an uninhibited contraction even when there is a small volume of urine or small volume of fluid. So remember, entire concept of neurogenic bladder, most of it is based on spinal cord injury. Everything else are derivatives of that. So spinal cord injury is the prototype. So initially spinal shock you have, so you get detrusor areflexion. Then there is the recovery of the bladder functions. By 6 to 8 weeks you can have uninhibited bladder contractions. Coming to a sacral spinal cord lesion, again these are the condition caudal equina, conus medullaris. So this is an autonomous bladder. This bladder, you must remember, tone is likely to be flaccid. You will in reality not get a perfectly flaccid one, but mostly it will be flaccid. And so the capacity of the bladder will be large, lot of urine is remaining, so over distension is occurring. So what you will have is overflow incontinence with no urgency. So whenever a patient comes to you, you think of what you are expecting and you cross check with these. So if that is not the clear picture, UDS will give you where exactly you were wrong, which level you are going wrong, okay? Similarly, for peripheral lesion, you might have sensory neurogenic bladder, motor paralytic bladder, different causes are there. I always pose. Okay, so there's the sensory neurogenic bladder, again same thing, over distension, high risk of infection. Now bladder sensation is impaired, so you have to be very careful when you're teaching this patient for CIC, trauma risks are high. Then a motor paralytic bladder. Here again it is flaccid, but there is some sensation. So there might be painful retention of urine. There might be inability to initiate or maintain micturition. And again the reflexes, important bulbocavernous anal reflexes might be absent. Now, based on UDS, now this is the best way of classification. Either the bladder is unable to store or the bladder is unable to void. Okay? So if the bladder is unable to store, then problem is either in the bladder factors, that is hyperactivity, or the compliance is less, or there is some problem in the outlet, like the bladder neck sphincter has failed. And if there is a failure to empty, where is it? Again, there has to be a bladder problem. You can go for UDS. 5 years cut off for CIC. You can start teaching the child CIC. And again, you have to emphasize a lot on bladder training. Oxybutynin is recommended, botulinum toxin, and if nothing works, surgical reconstruction. Things like, Mitanov's procedure and all this. You can consider. So what are the newer advances in neurogenic bladder management? Like Joshi sir had said in the morning, stem cell everywhere, stem cell everywhere. So here also there is tissue engineering and stem cell therapy. EMG biofeedback. This is present in a lot of rehab setups. Those who deal with neurorehabilitation, you might have it. And this is again a very good important point for rehabilitation, for reference. So many people might be referring to you simply for EMG biofeedback. So it might be wise to have that. Learn it, it's not rocket science. And it gives a lot of good feedback to the patient also. I can see exactly what's happening with me. But then you have to counsel the patient that 1-2 sessions is not going to do magic. At least 8 to 10 sessions will do. Transcranial magnetic stimulation, virtual reality, and of course post-COVID, nothing in rehab is possible without tele-rehab. So like I said, in neurogenic bladder, you have to be in touch with the patient. You have to regularly follow up because your dose modification, everything will change from time to time. So your paradigm shift should be, like I said in the beginning, it's not about what is the gold standard. It is sometimes about what the patient requires, what the patient needs, what is the social structure, the architectural structure, manual support. Accordingly you decide. It has to be personalized, safe and practical. So I come to the end of my talk with pranam to my father in PMR, late Professor Dr. Anirudh. And this is my baby department, just 4.5 months old. So we have started with very basic things, and we need your blessings and ideas. And if you are in Kolkata, please do drop in. Thank you. Is it time for questions or no questions? Okay. I'll be happy to answer any of your questions if you have. And do go through that article reference that I gave. It's a good one. All your queries will be clear regarding this. Thank you.
We will be having felicitation for this session. I would like to call Dr. Jaideep Nandi sir to felicitate Dr. Sanjay Pandey sir.